muscle strength that does not rely on increasing muscle mass. And I'd like to start by introducing Cytokinetics. We are a small biotech company in the San Francisco Bay Area, and the scientific platform of the company is based on motor proteins and contractile proteins in particular. And we rely upon the selectivity of different isoforms of major contractile proteins to give us selectivity for the different functions we seek to enhance. Our first drug that was in the clinic is partnered with Amgen and is an activator of cardiac myosin, which is being developed for the treatment of heart failure. And I'll talk to you today about our selective fast skeletal muscle troponin C activator program. Our approach is highly translational. We use a reconstituted sarcomere system to screen compounds and then move to cellular systems and finally intact organisms in our testing programs. This little movie just shows you the effect of our cardiac myosin activator on the cancer mecarbil. On the left is an echocardiogram of the left ventricle and atrium of a patient in congestive heart failure. You can see the poor movement of the walls of the heart and the septum, and the relatively shallow movement of the mitral valve, and the dilated size of the chambers. At the end of a 3-hour infusion of the drug, what you see is that chamber size has already shrunk, wall motion has improved, and you can see the much enhanced movement of the mitral valve, consequence to the increased flow of blood. So activation of the sarcomere on a very short-term time basis is indeed possible. So let's turn to our skeletal muscle troponin activators. And again, we followed a very similar paradigm to the cardiac, our myosin activator program, except of course our test systems will relate to skeletal muscle. I should point out, see if I can go back here, that our troponin activators, and the prototype is one we call CK2017357 or 357 for short, are very selective for fast skeletal muscle fibers because they're selective for the troponin C isoform in fast skeletal muscle. And what they do is they sensitize troponin C to calcium, essentially shift the calcium response relationship to the left, so you get more contraction of the sarcomere at lower levels of calcium in the cell. You can see the left shift here. This translates into a shift to the left in the force-frequency relationship. So in the light-colored bars here, you see the increase in force output or increasing stimulation frequencies in a rat nerve-muscle pair in vivo. And in the presence of the drug, you see a marked increase in the force output, particularly at low to moderate stimulation frequencies, which is where everyday activities are carried out. Once you get up near tetanic frequencies, there is not much of a difference in normal healthy muscle. And this relationship holds both in young animals as well as in old animals. So skeletal muscle in older rats, 2 years of age, responds very similarly to skeletal muscle of younger rats. We've looked at a number of disease models. This is a model of amyotrophic lateral sclerosis, the SOD1 mouse. And what you see here is a similar paradigm where we stimulate peripheral nerve, look at the force output of skeletal muscle in situ, and with increasing dose of the drug, you see increasing force output, both early in the disease when the animals become symptomatic, and later in the disease when these animals are moribund and need to be sacrificed. Obviously, less improvement in the older animals with greater degrees of denervation. We've also looked at a model of experimental autoimmune myasthenia gravis. In this model, animals are given an antibody to the acetylcholine receptor, produces a passive transfer IAGG, and again, dose-dependently, CK2017357 increases grip strength in this model. Along with the increasing force output, power output has also increased, derived from some of the previous data. And a very interesting property of troponin activator treatment is an increase in the resistance of muscle to fatigue. So in this experimental paradigm, the femoral artery is ligated and the nerve to the gastrocnemius muscle is stimulated. And here you see the tension time curve with repeated stimulation over 10 minutes. In the presence of femoral artery ligation, the muscle fatigues much more rapidly, but in the presence of drug, not only do you get a greater force output, but it takes longer to come back to baseline levels. So you have slowing of muscle fatigue as well. This is manifest here in this experiment in normal rats. They're fed drug in their chow for 7 days, and then what we do is we put them on a grid, turn the grid upside down, and simply wait to see how long it takes before they let go, and their hang time is increased in the presence of drug, and this effect is reversible when the drug is withdrawn and they're studied again 7 days later. So again, the three fundamental properties we find after troponin activation with CK357 are an amplification of the response to motor neuron input, an increase in muscle power, and slowing of the onset and reducing the degree of muscle fatigue. So we moved on to humans, and we looked at, we did our normal phase 1 studies, and then in part of one of those phase 1 studies, we looked at this experimental paradigm, in which we stimulate the perineal nerve at the knee, and the subject's foot is fixed to a force transducer, and we measure the force generated with dorsiflexion of the ankle with nerve stimulation. And the graph up here, what you see is a similar display to what I showed you from the rat experiments, is the force output at different stimulation frequencies, much lower in the human, and then the increase in force output compared to baseline generated at different plasma concentrations indicated over here of our drug. And above a plasma level of about 6 micrograms per milliliter, you see a concentration-dependent increase in force generation, again, at stimulation frequencies that would relate to normal levels of physical activity, much less of a relative increase as you approach tetanic frequency. So these three fundamental properties of skeletal muscle troponin activation, the amplification of response to motor neuron input, the increase in muscle power, and the decrease in fatigue, could translate into application in a number of different areas. Neuromuscular disorders, degenerative diseases of muscle, CNS disorders where there is weakness and fatigue, rehabilitation-related deficits, as well as age-related impairment, cachexia, frailty, and sarcopenia. We chose to look at three paradigms to explore the properties of our drug in patients, and we did three what we call evidence of effect studies, one in amyotrophic lateral sclerosis, one in myasthenia, and one in patients with exercise limitation due to claudication from peripheral artery disease. These evidence of effect studies are translational studies. They're hypothesis generating and not hypothesis testing, and they're designed to really explore this novel mechanism of action. So let's talk about the ALS study first. ALS, as you know, is a disease in which motor neurons degenerate, and we've recently heard a very nice presentation on the role of motor neuron degeneration and denervation in the deficits in sarcopenia. Obviously, this is much, much more severe in ALS. So this study was carried out in collaboration with the Northeast ALS Consortium in the United States under the directorship of Jeremy Scheffner from the State University of New York, Syracuse, and Dr. from Harvard. A very simple study. We had 67 patients in the study. It was a double-blind, randomized, placebo-controlled, 3-period crossover study. Everybody in the the study got a single dose of either placebo, 250 milligrams or 500 milligrams of the drug, in random order, double-blind, separated by about a week between doses. Again, the study was hypothesis-generating and not hypothesis testing. Multiple assessments were made with no single primary endpoint. There were multiple measures of function and fatigue. There was a global assessment, which I'll show you the results of. We made no adjustments for multiple comparisons with multiple measures that was tested with its exploratory nature. We used the study to characterize the pharmacokinetic and pharmacodynamic relationships of the drug and to assess the safety and tolerability of the single doses. It was a pretty typical ALS population. I'm not going to run through the demographics, other than to say that these folks were functioning at about 75% of normal levels. CK-357 has very nice pharmacokinetic properties. The half-life of the drug is about 12 hours. It reaches peak concentrations in the plasma around 6 hours, and concentrations, particularly at the higher dose we used in the study, in the plasma at 24 hours are still above that threshold I showed you of 5 or 6 micrograms per mil required for activity. Let me first show you the global assessment. Oh, this looked a lot better when I screened it before. I don't know what happened here. What was very interesting is we asked the patients to simply state, are you better, worse, or no different than before you got your dose of drug this morning on each of the study days. And we asked the investigators to say, is the patient better, worse, or no different than at the start of the study day. And both investigators and patients, both patients reported themselves as being better in an increasing proportion of dose, as did the investigators. And this was masked, and this also went along with the plasma concentrations of the drug. And there was about a 70% concordance here between patient and investigator. So what might be underlying it? One of the more interesting outcome measures we had here was something we called submaximal hand grip endurance. And we used an electronic dynamometer, and the way this differs from the standard JMR dynamometer is that there's a view screen here which gives a readout and visual feedback to the patient. So what we asked them to do is give a maximal effort. And then we asked them to maintain a grip for up to 2 minutes at 30% of their maximal effort. So this is about the amount of effort that it takes to lift a glass of water, or that you exert on a pen when you're writing if you are a normal person without ALS. And then we recorded the time it took them to fall to 60, 70, 80% of their preset target. And what you see is that the time taken to fall to these lower levels of activity increases in proportion to dose and approaches statistical significance when you get down to about 60 or 70% of normal effort. So you have an increase in what we've termed submaximal hand grip fatigue. We also looked at a number of measures of pulmonary function, obviously very important in ALS. We looked at vital capacity. Not much going on here, changes of about 2% relative to a maximum scale of 100%, but a slight trend towards improvement at 24 hours after the dose. We also looked at sniff inspiratory pressure. What we do for this is the patient is apt to give a maximal inhalation through the nostril, with the other nostril included. And again, dose-related increases in the force generated. This is a nice measure of diaphragmatic function. But perhaps the most interesting measure is what we call maximum voluntary ventilation. In this maneuver, patients are asked to breathe in and out as deeply and rapidly as they can for 10 seconds. It's a measure that integrates inspiration and expiration. It's very fatiguing, and the output is a unit of work. It's the amount of air moved per minute, or in liters per minute. And here you see at 6 and at 24 hours a nice dose-dependent increase in the volume of air moved, and it achieves nominal statistical significance at both 6 and 24 hours at the 500 milligram dose. We looked at strength of selected appendicular muscles using handheld dynamometry, as is customary in ALS clinical trials, and we saw small increases of up to about 2% predicted for age, gender, and body size for elbow flexion, shoulder flexion, ankle dorsiflexion, and knee extension. But in some instances, for example, flexion, the data was a little confusing. Hip flexion, which is sort of difficult to measure with this technique technically due to the leverage, we actually saw things go the wrong way. But we did have small and reproducible increases in some muscles that are very, very important to function. The safety profile of the drug is seen on this slide. The most common adverse event was dizziness, and this was characterized by the patients not really as a whirling vertigo, not in your syncopal type experience, but as feeling sort of buzzed like they had a glass or two of wine. We had no falls in the study, and the adverse events you see here of gait disturbance and balance disorder did not correlate with this dizziness sensation. We also had another thing here which is termed euphoric mood, which was dose dependent, probably another way of terming the same experience as we learned from talking to our investigators. So from this study we learned that single doses of CK2017357 were safe and well tolerated in this population. The patients and investigators both perceived a positive change in overall functional well-being, that there were dose-dependent increases in endurance that we feel probably is the major factor underlying this perception. We also had improvements in muscle strength. My co-chair is coming up, which means I'm running out of time, so let me talk quickly about our study in claudication. A very similar paradigm, except our major outcome measure was a 6-minute walk test and a heel raise maneuver, which patients were asked to go up on the balls of their feet. They were paced with a metronome, and we had this electronic goniometer that traced the movement through space, which allowed us to generate a measure of work. And what we saw is that at 6 hours after a single dose, patients were able to last longer before they had to stop due to claudication pain. They were able to complete more repetitions, although it wasn't statistically significant. But most remarkably, the amount of work, as calculated from the distance moved and the patient's body weight, significantly increased in relationship to dose and as well in relationship to plasma concentration of the drug. Unfortunately, the 6-minute walk time didn't improve. At the lower doses, there were slight decreases that were not statistically significantly different from placebo, but at the high dose, there was a decrease of about 100 feet on a baseline of 1,000 feet for this group of patients, of a decrease. And we feel this is probably related again to this dizziness side effect, which was very prevalent, 82% of patients at the higher dose, and slightly more prevalent at the lower doses in this population, which was older than the ALS population and probably had more white matter disease in their brain and perhaps was more neurologically impaired. So what we learned from this study is we were able to increase calf muscle performance in patients with claudication, evidenced by the heel raise testing, that both this increase in performance and the adverse events, again, were related to dose and plasma concentration. The 6-minute walk test was